I had the option to talk about anything, and pediatric hip, the painful pediatric hip is something that's come up recently, and people have been asking me how to manage it. And I know a lot of you don't necessarily do pediatrics, but some of the issues are relevant to any age patient in terms of what kind of imaging is best. As you know, when we consider the differential, we've got a long list ranging from traumatic to neoplastic to inflammatory to congenital. And it can be a little overwhelming when you're presented with somebody, my hip hurts, what should I do? It's helpful in children to divide the differential into ages, because I think that can help you get a handle on, based on this age patient, what am I likely to see? So for me, the three groups of kids would be sort of babies up to toddlers, so birth to age 3, and then age 4 to 10, and then adolescents, because with puberty and the rapid growth and hormones, that brings a separate set of issues. So let's see, so now we'll catch up. All right, so as I said, we're going to talk about some common causes. We don't have very long, so we're going to move along. We're going to divide it by age groups. So advance. And okay, so first, in the little kids, we're going to talk about septic arthritis. And I'm going to stress this because this is important. You do not want to miss this, because if you delay treatment, you can end up really causing permanent damage to the child's hip. I'm sneaking in developmental dysplasia of the hip. If you have a bad hip, it probably causes a limp. It doesn't necessarily make it painful, but this is something I get asked a lot about how to image, so I do want to mention this. And then, of course, in little children, you always want to think, is there a fracture that either the child can't tell me about or the caregivers don't necessarily want me to know about? Then as we move on to adult children, that's when we start to see leg calviprothase disease. They can have a joint effusion that's not affected, which in little boys, transient synovitis, and JRA starts to present. And then in bigger kids, we start seeing things that are related to pubertal issues, like I said, slipped capital femoral epiphysis, avulsion injuries, and neoplasms. Now there's some issues that are good for all age children, and like I said, again, I'm going to keep talking about infection because it's so important to figure it out quickly. Septic arthritis, osteomyelitis, and then fracture. So go ahead. So now septic arthritis, like I said, it's an emergency. You need to figure it out because you need to get that infected fluid out of there, because you can end up destroying the joint. Your clinical evaluation, of course, is critical. You want to see, do they have a fever? Is their white count up? What's their SED rate? What's the C-reactive protein? And once their SED rate's up, they've got a fever, and their white count's up, you need to be thinking infection. So when they come in and the child is saying, or may not be able to really articulate their hip is hurting, we can always start with a plain film. And I like plain films because it's a good, quick, cheap, easy to do in a lot of settings, hospital, outpatient clinic, that gives you a good overview. Is there a fracture? Is there some horrible mass lesion? But it lets you look at the bones. And please, when you're worried about the right hip, order the pelvis. Don't just order the right hip, because we need to be able to compare side to side, because things change with age. And I see people nodding. That's good. Of course, the problem always is that optimal positioning is a little difficult because their hip hurts. They don't want to lie flat on the table. And if they're 2, they don't see any point in doing it. And then the other thing you need to know is, I'm happy we got this film, because I can say, well, I don't see bad fracture, I don't see just gross destruction of the joint, I don't see fracture. But even if it's normal, I put at the end of my report, if you're specifically concerned about joint fluid, please get an ultrasound, because it's way more sensitive. This was read as normal, and I would have concurred by a very good musculoskeletal radiologist, but we went on because of the symptoms and ordered a hip ultrasound. And as we can see, these are 2 pictures of the right and left hip from the same patient. Now what you're looking at, Amy, if you go back real quick, what we're looking at is, let's see, does my thing work? What we're looking at is, here's the epiphysis, and then the growth plate, and then the metaphysis. So when we do the ultrasound, we lie them flat down on the table, we take a linear transducer, and we're right there over the joint space. So then go forward. So this is what we're looking at. I'm standing, this is their skin, I'm looking down, so here's their epiphysis, then the metaphysis, and then this is the long shaft of the femur. And here's the normal joint capsule that reflects back on itself, but it's collapsed because it's basically empty. There's always a trace of fluid, but it's basically empty. On the other side, boop, it's popped open because there's fluid in there. This is a very binary test. It's a yes or no. There's, when the child leaves, I am sure if they have a joint effusion or not. I like things like that. Medicine's got too much gray, maybe. But this will tell you yes or no, they've got a joint effusion. Now, it's like looking down into a small hole, so you're very certain about that one area. But it is not specific for whether it's infected or not. So the orthopedists love it, because we can say, we know there's a joint effusion, it's worth you, going after it. Although it's getting so that we do a lot of the taps. The differential, it could be anything. It could be infectious, inflammatory. Older children will have a transient synovitis. It could be traumatic, and sometimes even a foreign body. So as always, the history is the most important thing. Did they fall on a thorn? Did they have a puncture mark? Okay, go forward. And then what we can help with next is one of the times we can actually help with treatment. We can do an aspiration. It used to be done fluoroscopically, and here you see a needle being put under fluoroscopic guidance into the joint space. We much prefer to do children and anybody really under ultrasound. Here's a where you see this big fluid collection. Our interventional radiologists do these, Sue being one of them. You take a little needle and come right directly down into the space. We can do it in the ultrasound room, give them conscious sedation, and get it done and send it off and then see if they have an infection. Okay. Now, while we're talking about infection, we want to talk about osteomyelitis. And interestingly, particularly in young children, sometimes they can have both. They can have septic arthritis and osteo. Osteo is usually in the metaphyses, which are the ends of the long bones. It's hematogynous. It's most common in periods of rapid growth. In children, it's more common in the younger end than the older end. A little bit older patient than septic arthritis, but still relatively young. Staph aureus is still the most frequent pathogen, but we're seeing more MRSA. And with the MRSA, we're seeing more extra osseous complications. Okay. This is a study my daughter's learning how to make slides for school in 7th grade, and she told me this slide would get an F because it's got too many words on it. So I'm glad that y'all are not teachers from her school. But the basic point was saying that, clinically, a lot of things in terms of the lab findings are the same, but it does help to know that septic arthritis tends to be in the weight-bearing joint. So it is going to be hip, number one. So if they're complaining about hip, it's most likely that it's more likely to be a septic arthritis. Osteomyelitis in children tends to be one joint, tends to be, tibia, the tibia and femur. Depending on, in this specific study, it's tibia more than femur, and then calcaneus. And what will happen is, it's not your issue, not my issue. Once we figured out they have a joint effusion, sometimes the orthopedic surgeons will say, well, we know they've got septic arthritis. If they need to know if they've also got an osteo to determine length of treatment, they'll then get an MRI. Okay. So let's look at how we worked up a couple of kids, because again, one of my goals is for us to all be comfortable and on the same page about how we're going to evaluate problems. Now, yes, I know this is not a hip, this is a foot, but more osteo tends to not be, straightforward osteo doesn't tend to be so much in the hip, but these cases still make the point. This is a 9-year-old boy that came in just recently. He's having ankle pain. There's a bit of a red herring in that he'd had a possible injury at football practice 2 days earlier. But he had plain films the day he came in. It showed a little soft tissue swelling anterior to his ankle, but no bony abnormalities. Even in retrospect, I think the bone was absolutely fine. He went home, and 6 days later came back, and the poor child, he was in agony. His ankle was swollen, it was red, he screamed if you touched it. He was having a bone scan because his doctor was trying to figure out what was going on, and sure enough, it really lights up in his distal tibia, and there's some hyperemia, secondary hyperemia, and it's up his tibia and down in his foot. But here's the problem with the bone scan. It does a very good job of showing where the abnormal activity is, and it lets you look at the whole body, which particularly a little kid who can't talk and sometimes you can't tell, that can be helpful. But it only tells you that there's increased activity. It doesn't narrow it down at all. It could be a fracture, it could be a tumor, it could be an infection. So we had to get plain films again. That's not a big deal. And you can see that in 6 days now, his bone is just getting chewed up, and he had osteomyelitis. Now, he was so symptomatic that he went straight to the OR from there. When they got in there, he did have a little subperiosteal abscess that they were in there, so they drained it, so it didn't matter. But you would never know that from the bone scan, and an MRI would have shown that. Okay, so now we'll go on. This is another little girl, 18 months old, and how many times do we hear this? Refuses to bear weight, won't put her foot down. Well, who knows? That could be everything from, I don't want to get my Barbie sandal dirty to, I've broken my leg. Her plain films were normal. Now, again, we know, and this is one thing I want to make sure that all y'all understand. And I agree with this reading, the plain film was normal. If you know your patient better than we do. If we say the plain film's normal, that's good. There's no big fracture, there's no huge tumor, there's no huge obvious thing that we're going to, but that doesn't mean there's nothing coming or nothing going wrong, and that's important. So, because X-ray findings can lag behind for up to 2 weeks, so then we can go ahead. And then, but she went ahead and had, I think because of her lab findings and everything, she went ahead and had an MRI right then. And we can see in her left tibia the really abnormal signal down here compared to, this is the marrow signal in her distal right tibia. And then we can see this edema tracking up along her leg. Now there's no focal abscess here, but if there were, we'd see it. So we get to see not only what's going on in the bone, we get the global picture of the surrounding soft tissue. Okay. I like this paper. This is a recent paper from Pediatric Radiology. It's the only journal I read, y'all. No, that's not, just kidding. But they looked at 199 children that they knew had Staph aureus osteo. 160 had an MRI, and they found that it was 98% sensitive. 35% had a bone scan, and they found it 53% of the time. The important thing is, to me, is the extra osseous complications that they can only find on MRI, because some of these need intervention, like we've already talked about, septic arthritis. You want to tap and treat that joint as quickly as you can. Subperiosteal abscesses may need drainage, and a DVT, you want to know about too. Okay, so go ahead. So from this paper, they ended up with this algorithm, which I think is really right, and it's a big departure from when I was a resident. If you have bone pain and fever, get plain films, and then move on to an MRI. So the poor bone scan is becoming less pertinent. Unless, for me, it's still important if somebody's got an FUO and you just cannot figure out what's wrong and what's going on, and you need a way to look, a big global look in somebody that you can't get, or maybe in a young child that they're limping. Sometimes it's hard to figure out which leg is really hurting if you needed to see both lower extremities. But MRIs, and the smaller you are, the more MRI can get at once. So I think it's always worth asking, what do you think? Is MRI good, or is there any role for a bone scan? Usually, I think most radiologists are going to say get a bone scan. So now MRI. Oh, sorry. Yeah, sorry. My husband does MRI, so he's like watching to make sure I don't give anything away. So, okay, so now here's one more case to kind of tie all of this together. Our 5-year-old comes in and has left groin pain. It's killing him. So we send him to the office and we do plain films. And these were read as normal, and I agree, they look normal. But we say his left hip's really killing him. The pediatrician says, well, let's make sure he doesn't have a joint infusion. I say, sure, that's easy. Well, I can pick him up, walk him over to ultrasound, and do it right then. It takes about 5 or 10 minutes. So we do the ultrasound, and we see, here's his right hip. The epiphysis, remember, looking down. His head's up here, his feet are down here. We see the joint capsule. It's not distended, and it's not distended here. So he doesn't have a joint effusion. That's good. He doesn't have septic arthritis. We got a little time to figure out what's going on. But the patient is in a lot of pain. Well, what have we looked at? We've looked at his bones, and then we've looked specifically at his joint space, but it's like we're looking through a periscope at a very small space. We go ahead and get the MRI of his hips. Okay, go ahead. And what we see is these striking findings of abnormal signal on both sides of the right SI joint. A lot of edema. And then we notice this, and this is consistent with osteomyelitis, and this little fluid collection deep to his right iliacus muscle. So go ahead. We give gadolinium, and we can see that there is a little deep abscess collection there. A bone scan would have shown all this activity, and you would have known he had osteo, but you wouldn't see that. You wouldn't see the soft tissue finding of the abscess.
What are the risk factors there? Sickle cell or trauma? Or
for getting this? Oh, for getting like an abscess like that? Of getting a sacroiliac infection? Well, it can spread hematogenous, or you can have trauma. And what's scary to me? I've started doing radiology in '87 and peds in '83, and I see a lot more deep pelvic stuff than I ever did. I mean, deep gluteal abscesses, stuff deep in the pelvis like this, deep to the iliacus muscle. I don't know if y'all are finding that, but it's definitely a lot more in the last 5 years, and I think it behooves all of us to pay attention to that. I don't know why. Is it because there's more MRSA? Is it more virulent? I don't know. I don't know if the powers that be. And then again, why not a bone scan? Well, it doesn't evaluate the extraosseous tissues. The resolution is better. And this is, people say, well, instead of a bone scan, we better get a 3-phase bone scan. It's like, sounds good in the movies. Like, in ER, they never say, get a chest CT. They always say, get a high-res chest CT, because it sounds so good. Well, what are you saying? It's just a type of exam. The problem with I had an orthopedic surgeon yell at me that I didn't do a 3-phase of the whole body. You can't. If you want to do 3-phase, that means you're injecting the contrast, and you want to see how it's handled immediately, then on blood pool images, then on delayed image. So that means you're picking an area, and you're trying to assess abnormality in soft tissue versus bone in that area. So if you're doing like a 3-phase, you would have to pick one area. You can't get the whole body. You can always get the whole body on delayeds, but so the 3-phase, it just helps you decide. It's really sore and red and tender here. Is it cellulitis or is it deep infection? It does help you sort out soft tissue versus bone. But again, when you're trying to look at osteomyelitis, MRI is going to be much better. Okay. All right, now, and just a quick word about fractures. Y'all are such a huge help when you give a specific history about what happened. That helps us make sure we've got the right views, the right films. This is a 3-year-old girl who unfortunately fell out of a window and does have a fracture through her right iliac bone. Before I knew about it, she'd had a CT too. Well, you know, this is a non-displaced fracture. Did she really need this? Certainly, if an orthopedic surgeon needs to see a fracture, you know, you've got a complicated ankle fracture or something, that they need the details before they're going to pin it, by all means. But don't just order it because it sounds bad. If it's not displaced, we've given her a fair dose of radiation to her pelvis without providing, without providing enough additional information to make it worth the dose. Okay. Okay, now we're moving on to, I just want to talk about developmental dysplasia 1 minute, okay? As y'all know, the etiology is multifactorial. It's probably genetic, it can be family history, it can be the hormonal, it can be mechanical, were they a breech baby? Is it the concept of the tight uterine packing? Is it a first pregnancy? Is it a multiparous pregnancy? Are there a lot of babies in there? Is for some reason the baby being held in a weird space where the hip is being held at a funny angle and can't develop normally? So, so if you have a female breech twin, I'm more worried than if it's a single male baby who was born kind of early. It's more common in females, more common on the left than on the right. What we do is, offices call me all the time and ask me when to schedule it. Every orthopedic surgeon will say, well, hey, let's get it right at birth. That'd be great. Well, we don't do that for 2 reasons. The hip is continuing to develop after birth, and it takes about 3 months to fully mature. Also at birth, the maternal hormones that loosen up the mom's ligaments are loosening up the baby. So a lot of hips look loose and abnormal, and the acetabular's not fully formed. So a lot of times we're going to say, this is probably just all physiologic immaturity, but they're going to have to come back. So they're ending up getting 2 ultrasounds for some that's probably going to be normal anyway. As a radiologist, I would say, well, let's see everybody at 3 months when all the physiologic immaturity should be gone. And then the orthopedic surgeon is saying, well, wait a minute, let's don't do that, because then we're missing a chance to start treatment. So the sort of standard is look at about 6 weeks. And I tell the parents, this isn't like complicated science, it's just half of 3 months. You know, the fathers always look disappointed, like, well, then it was the X power of the, quantum. But it's just half of 3 months. Since more babies are born prematurely, take that into account when you're sending them. It doesn't matter if they're 38 weeks, but if they're like 32 or 33, push them to come a little later. You know, come at 8 weeks, 10 weeks. And again, the whole concept is, why are you doing it? If you're doing it as a rule out or a low pretest probability, yeah, they're a breech baby, but on your exam, everything looks fine, that's great. We're happy to do it, but send them at 6 to 8 weeks. Of course, if you're worried the hip's dislocating, the folds are really uneven, that you're worried there's something right now and they need to see an orthopedic surgeon, please send them right away, okay? So, and then just know that after 4 months, it starts getting really hard for us because the femoral head is ossifying more. This is just what one looks like. So you can see, this is a normal hip. This is ultrasound, the head's up this way, feet are down this way. We're coming in from the sides. This is the ilium, and then this is the femoral head sitting down in the nicely formed acetabulum. It's securely down in that joint. This femoral head is way out laterally, and when we pushed on it, it was dislocating up, and the acetabulum, as you can see, instead of being this nice cup, is really shallow. And when I report the alpha angles, that's this angle. It should be greater than 60 degrees, which, you can see if this is 60 degrees, then that's nice and mature. Okay, and then go ahead. And if they get older, we still can do plain films. It's not that big of a deal. You can see that these femoral heads are well seated within there, and then we can measure angles here. This is a case of a bilateral dislocation, and I will tell you, it's humbling. Those are harder to pick up than you would think when it's bilateral because it's symmetric. Now, just a tiny little sidebar on spines for sacral dimple. Feel free to send those the minute they're born. I'd love to have them come down right while they're in the nursery because they're sleeping all the time, they don't move. They're really easy to do. Those get much harder to do after 3 months too. So the hips, they need to be a certain age, but the spines, send them, they can come right away. I like seeing all those cute little babies. Okay, go ahead. Okay, now, then occult fractures. It wouldn't be a pediatric radiology talk if I didn't mention child abuse at least once. What I'm just saying about the little children is this child came in, his parents were saying she wouldn't move her hip, wouldn't move her hip. We got films. Fortunately, I didn't show you the hip film. You just caught the edge of that. And then they x-rayed her leg. And I think they knew something was wrong, but she had both. But if just the hip film, you barely would have seen it. But she had she's 2 months old and has a through and through oblique femur fracture. Nobody can think of any reason that would have happened. So it turned out, of course, that this was child abuse. try to think about that as it's going on because they may need a skeletal survey. Okay, now we're getting up to the bigger kids, and again, we talked about joint effusions, which you'll see you can have non-infectious joint effusions in older kids, tend to be like, I think of like 4-year-old boys. You'll see that on the hip ultrasound. Clinical data can help you decide whether you need to aspirate it. Juvenile rheumatoid arthritis, again, we hope clinical data will steer you towards the right diagnosis, but ultrasound is a good way to look at the effusion. So I want to spend just a minute talking about leg calvi-Perthes disease. And it is the most common serious disorder in school-age children, and it's just avascular necrosis of the femoral head. And if it's, unfortunately, the head usually will grow back, but depending on its shape, if it's sort of flattened and deformed, they end up with a bad articulation with acetabulum and can end up with cartilage destruction, which leads to early degenerative osteoarthritis in their hip, and so they're having problems in their 30s instead of their 60s. They come in limping. The typical thing is like a white 4 to 8-year-old male who's short for age, kind of delayed maturity. It can be seen in boys and girls, though, but it's much more common in boys. Okay, here's what we see. Now again, I'm sorry these films are coming out so white, but this child had been having hip pain for 2 weeks. And really, in retrospect, I wonder, is this just a teeny bit flattened, but very easy for me to say in hindsight. So basically this was read as normal, and I agree. She'd had a fall. People always find something to attribute whatever their symptoms are. You got to be careful that you don't necessarily believe that that's the problem. That looked fine. The doctor, bless her heart, was persistent, brought the child back a month later, and now we see a little lucency in the left femoral head. And when on the close-up view, we can see there's a little subchondral fracture. That's a classic finding in leg calvi-Perthes because the blood supply to the epiphysis has been cut off. So now they've got necrotic bone. It's starting to collapse and fissure. It gets dense, irregular, short. That's the classic triad of leg calvi-Perthes disease. Again, this is one where you want both hips at once because you need the comparison, and you need frog leg views. Now, frog leg views are you abduct and you rotate them out. So when the child's lying on the table, they look like a frog. And that's because this little fissure tends to be in the anterolateral part, so when you roll it out, you're going to see it better. Okay, so go ahead. And so here, what you'll see, they tend to go through 3 phases. The collapse, then it's kind of stable. It's like collapsing, getting worse for 18 months, and kind of stable for 18 months, and then it starts to regenerate. But you'll see how this head is getting denser. You notice it more on that. The head's getting flat. And over time, unfortunately, the neck gets wider. And when as they start to revascularize initially, the bone will still be dense. But over a long time, it can come back to looking more normal. Okay, what? Again, now here, I love MRI for this. If you're worried about that, once we get that concerning plain film, we'll get an MRI. It's much more sensitive, lets you be very specific. Here you see where this sequence where the signal is bright fluid, like here's the bladder, bright. You see fluid in that little fissure. Again, this is the same time we're trying to look on a bone scan. What you're looking for is you're hoping you're going to see a little area where there isn't perfusion. And that's hard. So it's a little, one of my bosses who hated nuclear medicine used to say he didn't trust any field where you had to take your glasses off to read the film. So, okay, go ahead. And again, part of it is, it's an idiopathic cause. A lot of times treatment is getting them off of it. As you know, the younger they are, the better they tend to do. Unfortunately, over time, though, they tend to get coxa magna, breva, and plana. Now, this is the teenagers. They're sort of fun. I like kids because you're dealing with different entities at every era. And this one, it's all about growth. They're growing fast. Things are changing. It's hard on their body. It's sort of ironic. I read something our daughter was, we were captives of the castle soccer system for many years. And and I'm sorry if anybody in the room that I'm offending, but it's funny, you watch them out there, the very kids with the open growth plates, the most vulnerable skeletons are the ones that they're pounding away, running back and forth on those rock hard fields. But slip capital femoral epiphysis is a Salter-Harris 1 fracture through the proximal physis, through the growth plate of the femur. Well, what's happening? It occurs during the growth spurt during puberty. This is sort of vulnerable right here, and they've got all this force is coming down here. The pelvis is pushing down and out, the pelvis on the femur. And if you're a big, tall kid who's overweight, that's even worse. It's even more pressure. Okay, so flip ahead. The patients, as opposed to leg calvi-Perthes, which is the classic thing, sort of like a 4 or 5-year-old white male, kind of small for age, these kids tend to be teenagers. In males, it's 12 to 15. Females 10 to 3. Again, more common in males and female, more common in black than white. It tends to be overweight, tall for kids, skeletally immature. They have hip pain and limp. And I love this. Go ahead. I don't know, do y'all remember this cartoon? I love this cartoon when I was little, and my favorite character was Fat Albert. He is a great image to get in your head because he is the body habitus that you need to be careful to think about. And this is important because some of these children only have knee pain. And I have a great story to tell about this. When I was at the University of Alabama, you sat and read, it was like a dream. You sat and read films, outpatient films, and the family, after they had their film, and then there was a door right here that I could just open it and yell into the room. The family would be sitting there waiting to see if they could go. Well, it was awesome. If I had any question, I could just open the door and say, Billy, where's your leg hurt? Well, so the kid has come in because he's having knee pain. So we get the knee films, and they're completely normal. And I open the door to say, Billy, and it's this kid, big, tall, heavy. I mean, he looks like, hey, Fat Albert. And I said, before you go, we need to x-ray your hips. And sure enough, he had slipped capital femoral epiphysis. No hip pain at all, even on asking him. Well, his pediatrician was great. She really got fired up about that. So she was like, ever after that, everybody came in for hips and knees. And within a year and a half, she found another one like that. The boy only had, so if I guess if you get nothing else from this talk, remember that. If they're complaining of knee pain, but they're a teenage boy with that kind of profile, think about maybe it's their hips. Okay, and again, what's happening is we're going to get plain films are good, but we need, again, the AP and the frog leg, so two views, because what's happening is the hip is slipping back, the epiphysis, it's like the ice cream on the cone. It's falling back and medially. You know, they're all going to go posteriorly, 99%, but 75% of them slip medially too. So you'll see the growth plate is widened, but you should notice that the edges aren't lining up anymore, okay? And again, on this film, this is a 13-year-old with right hip pain. This looks pretty good. You know, you're saying, here's my ice cream. Is it centered on my cone? I don't want to drop my ice cream. It looks okay there, but it's sort of scary. This is the frog leg view. You know, we abducted and rolled his hip out. Look at that. It's coming off. It's coming down here. It's not where it should be. He's got a slipped capital femoral epiphysis. And what they do is they pin it right where it is. If they try to drag it back up, evidently that does, there's a risk of really tearing and destroying the blood supply. And then you'll give them avascular necrosis. So they just pin it where it is. And I find on the follow-up films, I have to make myself look at the other side because they can have disease in the other side, either synchronously or either at the same time or later. And you get so distracted by this big pin, you forget to check that side. So far, he's okay. Okay, now we're almost finished. Avulsion injuries are again seen in pubertal kids because what is an avulsion injury? It's when you have a little bony fragment that's pulled off by sharp contraction of a tendon or ligament, and usually it's the apophysis. You know, the epiphyses are growth plate centers in the lines of growth. Apophyses are little sort of extra bony pieces that are developing and fusing during puberty, but during puberty a lot of them are still open. So that's why, and again, who's active? It's like 12, kids are out playing soccer, doing sports. You have many sites of apophyses, and you have others in the rest of your body, but in your hips, it's along your iliac crest. It's the anterior superior and anterior inferior iliac spine, and it's different muscle attachments, sartorius, rectus femoris, and then the ischial tuberosity down at the hamstrings, all these places. You pop that little bone off, and it really hurts, okay? So it's adolescent athletes, more common in boys than girls. It's seen in sports like sprinting, hurdling, tennis, soccer, ballet, sudden sharp pain with localized tenderness and swelling. The most common is the ischial tuberosity, followed by the superior and inferior spine. So this is first. The hamstrings will have like a pain deep in their groin, and then the superior and inferior iliac spines, okay? So here's one of our patients, a 13-year-old soccer player. At the end of practice, he told his mother, gosh, something happened during practice. I've got this terrible pain. He pulled the little apophysis off here. It's not interfering with sort of the main bone, but he's pulled this little side piece off right where his rectus femoris attaches. If they're really complaining and having a lot of pain and you can't see anything, an MRI would show a lot of edema in the muscle attachment there. And it can be helpful sometimes because when it's healing, it can look really ratty and irregular, especially down here in the hamstring, and people can be worried that it's a neoplasm, and MRI can help with that. Okay. Now, the thing we all dread, and I put it in last, is neoplasm. We have a new feature at our hospital where it comes out with these big, huge arrows, so it costs more, It shows where the answer is. No, somebody put these on it, and I could not figure out how to get them off, but at least they don't flash. But this is an interesting boy. He's 16 years old, poor, no money, doesn't speak English, and kept saying his hip hurt. And so they x-rayed him, and he's got this big expansile lesion in his inferior pubic ramus, and it goes up into his acetabulum. Interestingly, 3 years earlier, he'd fallen down most of a flight of steps. Was hurt enough that he came in on a backboard. Here's the backboard. And trying to look through the backboard, I don't see anything wrong with this hip. Well, I think this is an aneurysmal bone cyst. And they, a lot of times, start in something else. Fibrous dysplasia, subtle trauma. So you wonder, one of our MSK guys said he wants this as a teaching case because, as far as we can tell, there was nothing wrong 3 years ago. Now he's got this big lesion. So that would fit an aneurysmal bone cyst developing that. Well, we weren't sure what it was, but we got an MRI. And MRI in this case, I think, was really helpful because you see the multiple cystic area, multiple fluid-filled areas, and you can see some fluid levels, which really, I think, should be an aneurysmal bone cyst. I mean, I guess it could be a giant cell tumor, but it's less likely in somebody whose apophyses are still open. Okay, go ahead. This, unfortunately, is the more serious one. And again, the other point I want to make, besides recognizing the slip capital femoral epiphysis in big teenage boys, this girl's knee had been hurting for 2 months. She came in for films. They look normal, and they really do look normal. These are underdeveloped. She came back 9 months later for persistent pain. That's what we all don't want to happen. We don't want it to be 9 months. Fortunately, when she came back, and I tried to lighten this up so you can see it, there's a little cloudy kind of osseous density out there that really shouldn't be there. So she had an MRI, and unfortunately this shows a big permeative mass in her distal femur with a huge soft tissue component. That little bony ossification is in some of the neoplastic tissue out here. You can just tell how much edema and soft tissue and mass there is. And unfortunately, it turned out to be a sarcoma. And so this just underscores again that MRI is the best at looking at all the tissues. So we're going to, just the last couple of slides, if we're going to evaluate the painful hip, and honestly a lot of these things work for any bone, get plain films first. They're easily available, easy to do, low cost, great resolution. Ironically, we all love MRI and CT and everything. You're not going to get better spatial resolution than plain film. If you're looking at individual bone trabecula, the plain film's great. And please, if you're looking at the hip, get both sides. The comparison's helpful, and I think, particularly if you're worried about slip capital femoral epiphysis or leg perthes, it's good to have both views, AP and frog leg. Okay? Ultrasound, if you're worried about a joint fluid collection, it's great for that. We can very quickly tell, it's very binary. We're going to know yes or no if they've got it. And then MRI, great overview for all the tissues, great if you're worried about an abscess, an infection, tumor. And then CT, because of the radiation dose, be careful. Is there another way to do it that wouldn't have so much radiation dose? If you need it, it's a great test. And then bone scan, I really think it's diminishing. Its role is decreasing with the ever increasing use of MRI. Okay, so thank you.